So, hi everybody.
Hi.
Thank you so much for coming. So yeah, I'm Julia Smith, but you can call me Jules. It's a bit easier. Hello to everybody online as well. Thank you so much. So I'm going to talk about my most recent mission in Afghanistan. So yeah, if you want to have a look at the photo. I just want to say it was absolutely beautiful. You've probably heard from lots of other people that have been to Afghanistan that the landscape is just absolutely beautiful. But every morning we took a bus to work, and this is our view every morning. So it was absolutely amazing. My favourite. This is the Kunar River in eastern Afghanistan. Okay, so it's just an overview of what I'll discuss today. I'll do a bit of an introduction about myself. I'll talk a bit about the Afghanistan context. I will introduce the earthquake response that I worked in Kunar. And I'll also talk about the health promotion activities and the team that I worked with there. Also briefly talk a little bit about the challenges that we faced in the project. And finally, I'll talk about a new project assessment as well. So MSF are hoping to start a new project in East Afghanistan. It should be kind of starting very, very soon. I'm not sure what's going to happen because a few problems with Afghanistan and Pakistan attacking each other. So I'm not sure about that, but we'll talk about that next. So yeah, this photo here is just one of our explos that we did actually for the new project. It was really beautiful scenery. There's lots of greenery, but also lots of like dusty desert type mountains as well, but I'll show you some other photos as we go. So it's just an introduction. As I said, I'm Jules. I'm a health promotion, a community engagement manager. So I started off in MSF in 2022 as a health promotion supervisor. And then I went up to health promotion activity manager. And then it's kind of the same as health promotion community engagement manager. I think yeah, it's almost the same thing, but I think they've just changed the title a little bit. So picture is me in Afghanistan there, right in the tops of the mountains where the epicenter of the earthquake happened. It was really, really lovely. So I've done 4 missions, Sierra Leone, Iraq, South Sudan, and then Afghanistan is the most recent one. So I got back 6 weeks ago at the end of January. It was quite a short mission because it was an emergency project. So I was actually there from November to January, but the project actually started in September. So I arrived kind of halfway through the project was happening. A bit about my background. I was a HP or health promoter actually in the NHS, in the NHS Health Improvement Service in the northeast of England in Middlesbrough. So I did that for quite a few years. I was teaching basic nutrition. I was working in stop smoking clinics. I was based in GP surgeries, giving healthy lifestyle advice. So quite different health promotion to what we do in MSF, but still a lot of transferable kind of skills and knowledge. I also had experience in NHS sexual health clinics as sexual health advisors in Oxford and Hackney as well. So I'd say the majority of my background is actually working in sexual health. So where you can get tested for sexually transmitted infections, bloodborne viruses, you can get contraception, you can get basic counselling and health advice around anything from sexual assaults to female genital mutilation, that kind of thing. We covered a lot of things in the sexual health clinics. Also did a little bit of, on chlamydia screening in Hackney as well, and I also volunteered as for a refugee charity as well. So that's a little bit about my background. Also had some kind of brief work in child immunisation services and drug and alcohol services as well. So I've covered kind of a broad range of different health topics. So my plans now, I'm currently going to take a break from MSF just now to focus on a new NHS job in health promotion. And I'm continuing my master's in public health as well. It's just a bit about me. So you probably know a bit about Afghanistan working for MSF anyway, but I just want to give you a little bit of a context. So it's very mountainous in a lot of places, but also quite urban as well. So it's a very, very varied kind of landscape. So a lot of agriculture, farming, goat herding, that kind of thing. There's diverse ethnic tribes and languages as well. And it's also, I didn't know this actually before I went to Afghanistan, but it's on Afghanistan is under massive tectonic plates, so it's very, very prone to a lot of earthquakes. And whilst I was there, I did feel a few rumbles, very, very mild ones, which was a very, very strange feeling. Yes, and it's also prone to flooding as well. So the Taliban actually, they took over Afghanistan in 2021, and there's been a lot of changes since then. As you've probably seen in the media and what you've heard, it's the Taliban have imposed strict interpretation of Sharia law. So it includes girls being banned from studying secondary school. Also, women are not allowed to study at university, or they're not allowed to actually work in most jobs. Public spaces such as park gyms and clubs, they're not allowed to go to. So it's quite a big change, and I could really see that actually amongst the women. There it was really kind of, you can see the impression. It's when you're out in the streets, there's hardly any women there, and they're not allowed to work in their shops, or the things that they were doing normally before, they're just not able to do anymore. Also, women must have something called a mahram. This is they're not allowed to go anywhere without a male escort or male accompanying the woman anywhere as well. So this was quite challenging actually working in Afghanistan. So even as an international woman, I also had to have a mahram to escort me everywhere I went. I'm not allowed to go anywhere on my own. So yeah, in general, because of this gender issue, the strict interpretation of the Sharia law, women do have reduced access to healthcare, because also males cannot touch a woman or treat a woman as well, and also most of the kind of medical staff are also male as well. So it's
can female treat males?
No.
Yeah. Okay.
Yeah. So yeah, the same the other way around as well. So it's really challenging for women in particular who can't get out of the house without having a man, and when they get to a clinic, if there's no female staff, then they're not able to be treated as well. So also something I didn't really know much about before I went to Afghanistan, but there's so Pakistan and Iran are forcing Afghanis to leave the country and to go back to Afghanistan. So Afghanistan is having a massive influx of returnees from Pakistan and Iran in the country, which is also putting a really big strain on the healthcare system as well. I thought I'd put something at the bottom about the fertility rate. In Afghanistan, culturally, it's families do want to have a lot of children. So usually the families are quite big, and the fertility rate is almost 5 children per woman. So just a map of Afghanistan. So on the left, you can see Afghanistan in the white. It's surrounded by Pakistan, Tajikistan, Uzbekistan, Turkmenistan, and this is Iran. Where our office was in East Afghanistan was in Jalalabad. So you can see it's very close to the Pakistani border. On the right-hand side is a map of all the different ethnic tribes and languages in Afghanistan. So I was saying before, it's very diverse. So where Jalalabad was, it's the light green, which is the Pashtun tribe, and they speak a language called Pashto. And what we realized actually during the mission, they didn't just speak Pashto. There was also lots of other ethnic kind of languages and tribes as well that we didn't have staff to kind of speak the language. So that was definitely one of the challenges, which I'll discuss in a bit. I just stole this from the MSF website. This is all the MSF projects in Afghanistan at the moment. From 2023. So there's different sections working in Afghanistan, but the one I was working in Kunar was just where this blue star is here. This was an OCB project for the emergency earthquake response. Okay, so Kunar earthquake. I don't know did you hear about the earthquake last year? It happened, yeah. So it happened on the 31st of August last year. It happened around midnight. So people were in their beds sleeping, and it was really devastating. It was a level 6 on the Richter scale, which is quite severe. And I didn't know this before, but it was actually a shallow earthquake, which means it causes more destruction rather than a deep one. So actually a lot of the houses and the fields, agriculture, the animals, the people, everything was destroyed. It also actually triggered landslides and flooding in some of the mountains as well. So there was reported like more than 2,500 deaths, more than 3,000 injured, and almost 22,000 people displaced from their homes that have been destroyed to kind of temporary camps because of the earthquake. So the communities in Afghanistan were already facing a lot of poverty, limited healthcare access, and restrictive gender policies. And after the earthquake, we could really see this really worsened. These photos, I didn't take myself. They were just taken from kind of some news articles, but this is where Kunar, the earthquake. This one here at the bottom, they were discussing that it actually caused a lot of road damage as well. So a lot of the places in the mountains just had like a single winding kind of pathway, and a lot of the rocks would cover it, or it would damage it. So that would actually restrict people from getting help as well. So that was actually a really big barrier in getting healthcare support for these people. This is a map just of the earthquake. This is where the epicenter was, where the red dot is in the middle. And this is kind of like, I can't remember exactly the rings, but people can still feel the earthquake from this far out. So Jalalabad was where our MSF office was based. So in this whole circle, this is where people would have felt the earthquake, but the bit in the middle, the red bit, is where the epicenter was. This is where MSF was focusing on the project there. Again, this is just a photo that I found on the news page, but this is in Kunar as well. And you can see that the houses, they're made from stones and mud, and they don't have foundations. They're not kind of made very strong. They're just made from whatever they can find. So it caused so much devastation because of these houses were not kind of very strongly built, and because the earthquake was so strong, it really crushed a lot of people in the middle of the night whilst they were sleeping, and a lot of people died. So it's really sad. This is a photo that I took actually going to one of our camps. This isn't actually the camp that MSF supported, but you would see lots and lots of like temporary shelters and lots of camps everywhere you went, like in the mountains. But I just thought that would be a good picture just to show you. So people would move from the mountains and then kind of settle on like the flat land. So they were kind of away from the rocks and the mountains, just in case of any aftershocks. So I'm going to talk a little bit about what MSF did in Kunar. So we supported 2 internally displaced people camps. The first one was called Patang Camp, and that had about 6,000 people in there. So there was just rows and rows and rows of tents of people, families like living in these tents. Also, the second camp was called Arigamba Camp. It was also called Shamash as well, and that had about 2,000 to 3,000 people. And this is where the epicenter of the earthquake was. This Arigamba one was really high up in the mountains. You can see the background photo there, very high up, and it was very difficult to get to, like through these really winding roads. So you could really kind of see the devastation as you were going up through the mountains, and you could really kind of feel like how desperate these people must have been. So the MSF were there, I think it was very shortly after the earthquake, to support with the medical services, medical clinic. So they started in September, and then they closed in December and handed over to a local NGO, is Afghan Red Crescent. So the camp was generally managed by Afghan Red Crescent. So they would provide the people their tents, latrines, safe water. There was a school, a mosque, and daily food as well. But MSF were actually providing just the medical services. In some projects, MSF also provides like the water and sanitation as well. But in this particular one, it was just the medical services. So MSF initially provided trauma care following the earthquakes, a lot of kind of broken bones and wounds, that kind of thing. But it was mainly a primary healthcare project. So we had a little clinic in Patang Camp, which I'll show you next. Just providing all the types of things that you would normally go to a GP for, really is how I can best describe it. So include things like vaccinations. There's also a very basic maternity centre as well. So if there was a woman that was pregnant, she could go and get antenatal checks, postnatal checks, and there was even a delivery room as well. We also had a mental health team, which were providing psychological sessions and counselling sessions on a one-to-one basis. And also the health promotion team, which I was managing as well. So I had health promotion team going around and educating the communities. We also had an ambulance as well. So if there's anything that MSF couldn't deal with in the clinic, then we can refer to local government hospitals as well. So yes, the camps actually were 2 to 4 hours away from actually the base where we were living in Jalalabad, if you remember from the map from before. So yeah, Jalalabad. But we were going kind of right into the mountains. So sometimes it did take a very, very long time to get there. So we had a little minibus that would take us. This is Patang Camp, the largest camp. It's not the best photo. You can't really see the full scale of the camp, but Patang Camp had 3 separate camps, like within one camp. And this one here was the one that was furthest away, you can see in the corner. And there's a picture of me actually inside the camp with 2 of my colleagues there. So you can kind of see like the tents behind us. And this is the MSF clinic in the camp. I didn't take that many photos, so it's probably not the best photo, but the tent here in the middle, this is the health promotion tent. This is where my team would meet every morning, and we would sometimes do sessions in there or trainings. Here is like the maternity centre, and it's like a container that was a delivery room, and they do consultations in there as well. And this is like, so actually, as I didn't mention, there's male and female complete separation from in the clinic. So the female section was here, and then the male section was here, so completely separate. And the tent over there is that was the triage. So yeah, it was mainly kind of tents and containers really. And then at the end of the project, this was all kind of taken down, or it was donated to the Afghan Red Crescent. But you can see it's kind of surrounded by the mountains in the background. But this is on quite flat land. This one. This was the MSF clinic in where the epicenter of the earthquake was. Again, it's not a very good photo, I'm afraid, but this is a clinic behind, and this is when they were still kind of in construction. So you can see very, very high up. So actually MSF did actually support with providing water and sanitation in this particular clinic. So they built some latrines for the community as well. But yeah, this is just to show you kind of a little bit different to the big camp, but yeah, it was kind of temporary shelter, like tents that were provided from other NGOs. So just to kind of give you an overview of what were the kind of things that we saw in the MSF clinic. And the main infections that we saw was respiratory infections, especially amongst children. There's a lot of pneumonias, a lot of coughs, a lot of breathing difficulties. And I think that's down to quite a few different reasons. It's a lot of kind of burning of like wood or plastic, trying to stay warm. And also the cold weather. So pneumonia was one of the main things actually after we did the reports and ended the program. Pneumonia and the respiratory infections was one of the highest prevalence. There was a lot of hygiene related infections as well. So living in a displaced person camp, as you can probably imagine, the water and sanitation is not going to be as good as what you expect. So yeah, a lot of things like diarrhea, skin diseases and eye infections. We were treating a lot of those in the clinic as well. There was a lot of reports of just generalized pain as well. And also kind of mental health as well, as you could probably expect. A lot of these people have lost their family members, their children. They've been displaced. They're living in a really stressful condition. It's starting to get cold because it's winter. So yeah, so the mental health actually was also quite a big thing that we recognised as well. This is from the MSF website, but this is actually inside our the triage of the clinic. This is one of our nurses just taking the temperature from a child. Feel free to ask me questions along the way, by the way. It's fine. Feel free. So I'm going to talk about the health promotion team now. So my role as health promotion manager was to manage a team of health promotion staff. So these were all Afghani local staff that were recruited before I arrived in the project. My colleague here, Abdul Amin, he was my health promotion supervisor. And what was really amazing is during the earthquake response, MSF were able to borrow staff from other projects in Afghanistan. So Abdul Amin was from the Kunduz project. There were actually lots of staff, not just the health promotion, but the nurses, midwives. We had like a detachment of staff coming in to support like the earthquake response, which was really good for their learning as well. I had my supervisor who's Afghani, and then in the big camp I had 18 health promotion workers to look after. So they were going not door to door, but like tent to tent, and as a pair, and providing health education or information to the people of the community, basically. And in the epicenter of the earthquake, the Shamash, when we had 4 health promoters there. This is just a photo of my health promotion team. So before I arrived, actually, but this is the tent and what it looked like inside. This is our office. There was no chairs, actually. We had team meetings while I sat on the floor. And I got very flexible after that, actually. It was quite nice. So I'll mention a little bit more about the gender segregation, but it was even quite strict, actually, in work, that the male and the female staff also had to be segregated, separate from each other. And even our female staff were wearing the full burqa. Not all of them, but most of them felt more comfortable with the burqa because the Taliban were actually kind of hanging around. They weren't necessarily in the MSF clinic, but they were outside patrolling, and sometimes that they might come in and just check that we're kind of behaving in a way, or people are wearing the right clothing. So everyone was kind of a little bit worried that they don't want to get in trouble. So we had to kind of really stick with the rules, make sure the gender segregation was happening.
Excuse me.
Yeah.
Do you find that the men were prepared to listen to what the women had to say or were they not allowed to say anything?
I found that the women didn't feel confident speaking a lot in front of the men, but I was encouraged it. And I think the team was so lovely. I mean, my male colleagues were very, very respectful of the female colleagues, and they were also encouraging. But I'm not so sure if that was kind of like that everywhere. But I would say in general, I think it felt like a safe space for them to talk if they wanted to, or to raise their points. But it was definitely more the males that were doing more of the talking. You can't really see this here, but we did have a curtain actually dividing the room as well. So sometimes we'd have a team meeting with a curtain dividing the men and the women, which was really, it was kind of quite unusual. It was very difficult to get used to kind of that, really. So I don't know if you know much about health promotion managers or health promotion in the projects and what we do, but I just thought I'd kind of talk a little bit about what our day-to-day looks like. So my team would, as I was saying before, they would go from tent to tent and give information to the people of the camps. They would also remain in the clinics as well. So the patients coming into the clinic, they would also talk to them a bit about MSF and like just various different kind of health topics. So in this particular project, these are the topics that we prioritised. So in all MSF projects, the health promotion team will always do MSF service promotion. So they'll always explain to anyone coming in the clinic, this is MSF, this is who we are, this is our principles, we're neutral, we're independent, we're confidential, we don't judge anybody. So it's kind of a lot about explaining who MSF is and explaining what the services are and that we're free, as well as promoting antenatal care, postnatal care, contraception or birth planning, or giving birth safely in a facility, the benefits of child vaccinations, respiratory diseases and how to prevent them or how to kind of manage those, hygiene, including diarrhea and how to prevent that. Sorry, I've already mentioned birth spacing, but yeah, we would kind of it wasn't so popular, but we would always give people the option that we do have contraception here if you do feel like you want a little bit of a break from having a child. It's so it was kind of a little bit difficult to try and get people to really change their minds about it, because this might be the first time they've come into contact with someone giving you information about contraception. Also things like danger signs in pregnancy in children and what to do. So these are like the health topics that my team were broadly covering, and they were providing this information in different ways. So on the right hand side, like the activities that we did, health talks were a huge part of the health promotion role. So because a lot of the people don't read or write, they're illiterate in the communities, and also they speak different languages. We had images we call it flip charts, where you have images that you can discuss. It's an interactive health talk in a group setting. So we had kind of topics and flip charts for every one of these topics. And also sometimes we would do kind of storytelling as well, and also games as well, so for children. So things on like promoting hygiene, or how to wash your hands, when to wash your hands, kind of thing. So also the other activities that the team would do, so we did health talks, we did children's games, community engagement meetings with leaders and other NGOs. This is actually a big part of the role as health promotion, is because the health promotion team are the ones in the community. They're kind of like the link between the community and the medical services. So it's very, very important to make sure that you make links with the correct people in the community. They know who you are, they know who MSF is and what you do, and it's free. And also just to kind of give the community a voice as well. So we had regular meetings with the leaders of the camps, or the tribal leaders, or the elders. For example, this is one of our meetings actually with all the elders. So that would happen like once a week. We would gather all the elders together and ask them, how is everything going? Have you got any feedback about MSF? Is there anything you're concerned about? How is your community? Is there anything unusual health-wise in your community that you want to talk to us about? So it was giving the community a voice, and this is a really important part of the health promotion role as well. So this is me actually, but usually most women wouldn't be allowed to do that. So the men there were actually very, very kind and very respectful and welcoming to me, but usually that wouldn't kind of happen.
And which language did you communicate with?
So the majority of the people spoke Pashto, but there was another language called Pashai, which was like quite a minority language, which we realized that kind of later on. So we actually recruited some Pashai translators that could speak both of those. So we did actually have some staff that was there to kind of translate for the people that couldn't understand. And for me, I apologize. Yeah, I speak English. I tried to learn a bit of Pashto, but yeah, with 2.5 months there, it's kind of not enough time to learn very much.
Would they never have a local woman in there, or even just like one touch point at some point to talk about women's needs? So it's all filtered through the men.
It's all filtered through the men. Yeah. And they did actually have like some female leaders and elders, but whilst I was there, we weren't able to gather them because I didn't have any HPs, health promotion workers in my team that spoke English. So it was actually quite challenging that I would have held the meeting myself, but I would need to book a translator, and I don't have the links. I need a man to come with me to eat. And the gender thing was just kind of like, it got really complicated at times. But yeah, I mean, this was kind of quite a one-off really. I think the more the men got used to me, the more they were kind of more respectful, and the more that they saw that we were kind of there to listen to them and to help them. But yeah, no, I didn't encounter any problems. They were all very nice. So yeah, going back to the health promotion activities. So we were doing the community engagement meetings, not only with the leaders and the elders, but we were also meeting with like Afghan Red Crescent as well, who were managing the camp, because we often gathered kind of feedback or things that people were not particularly happy about the camp. And so we're advocating to Afghan Red Crescent, actually, these people have mentioned this, we just want to feed this back for you, just in case there's something that you can do. For example, complaints about the food that they were given, it's not enough food or not like enough good enough quality, or things to do with like the water and sanitation. So as that was not MSF's responsibility, we were just there to kind of advocate in a very sensitive way. But sometimes that could also be a bit tricky, because like Afghan Red Crescent might think that MSF are trying to tell us what to do. So yeah, you have to kind of really kind of build trust and relationships, and it does take a bit of time to do. So also the health promotion team plays a huge part in surveillance of diseases and infections. So when they were going to visit the tents and the communities, they would look out for anyone that was kind of sick, or they would look for children that haven't been vaccinated, or perhaps maybe a mother's given birth in her tent and she's not come to MSF clinic. So the HP team were also collecting this information and actually providing a referral slip to the patient to come and see us. You've given birth in your tent. You should come and see us. We can do a check. We can check your baby's okay. We can check you're okay. Or it could be we saw quite a lot of people that were just had, it looked like infected wounds or maybe broken bones, and they've tried to kind of like fix it themselves with a stick. So it was kind of those types of things that my team would be looking out for, to say, actually, I think you need to go to the clinic. Here's a referral slip. So yeah, the team were doing a lot of that as well, and also reporting on any new births or any deaths. It's kind of part of like public health surveillance that we would kind of share with the medical team as well. So we also did a lot of rapid assessments. So I was only there for 2.5 months, but we were asked to do a malnutrition rapid assessment, because we know with displaced people's camps, there's issues with food and lots of different things. They might be at a higher risk of malnutrition. So the health promotion team were asked to support the medical team in actually coordinating malnutrition assessment. So we actually went and screened every child under 5 and every pregnant and lactating woman in the 6,000 people in the camp. We checked for malnutrition. So that was a very, very big job, but it was actually very interesting. So the health promotion team, we get involved with other things like this as well. So it's not just kind of promoting health and giving health advice, it's also getting involved with other stuff. We also had an issue as well where we noticed that a lot of women were still deciding to give birth in their tent rather than coming to the MSF clinic. So we were really concerned, because our team are going and promoting the services and saying it's free, like please come to our clinic, it's safe, it's confidential, it's women only in the maternity clinic. But the women were still deciding that they wanted to give birth in their tent. So we did an assessment really just to kind of check what's going on here. Are we not doing our jobs properly in terms of promotion, or is it a cultural barrier? Why is that? So actually we did find out it was a cultural thing, that this is the first time that they have come into contact with a service like MSF. They're used to giving birth just in the mountains on their own without any medical input, and they're not used to it. They're embarrassed to kind of show their genitals in front of anyone that's not their husband or their mother. So it took a little while to kind of really gain their trust and really try and promote that it's a safe environment. There's no men here. But yeah, so we were getting involved with lots of things like that and kind of sharing this information with the medical team.
Use any like patient representatives to kind of bridge the gap between like staff at like MSF staff and the population?
We so the health promotion team were so some of the health promotion workers were actually from the community. So I would say that was probably the closest thing that we had. Yeah, but we didn't have like a specific
like patient experience, like anyone with kind of experience of using the services that have spoken to them.
No, I think it was more just the health promotion team that were kind of like bridging that kind of gap. But we did collect patient experience surveys. Is that also what you mean as well, or just?
Yeah, it's just interesting because you were saying that they're kind of, the service is new and they're uncertain about using it. And I just wondered whether kind of that like approach was used at all to
Yeah.
feel comfortable with it, I suppose.
Yeah, it would have been a good approach actually, but yeah, we didn't have anything like that in place. But I think the fact that our health promotion, some of the workers were actually from these camps themselves, we recruited them. That was actually really helpful in itself because then they could share that with their communities, and then we kind of gained trust like through them as well. Yeah. But yeah, also we were doing kind of regular staff trainings for the team as well, in the tent that you saw. And I was just mentioning before, the health promotion team were also collecting patient feedback. So on kind of satisfaction, we call it patient experience surveys now. So when patients have come to the MSF clinic, we want to know what's their experience. Did they have a good experience? Is there anything that we can improve? What did they not like about it? So we were collecting that type of data as well. Sorry, that was a bit of a kind of a long slide. Yeah, this is just an example of one of my health promotion workers. This is when he's doing a health talk to a group of men. So this is in the epicenter of the earthquake in the Shamash clinic that you can see. It's absolutely beautiful. I'm not sure which session he's doing, but we tried to do health talks. The typically female topics, such as kind of birth spacing or antenatal care. We were also doing these health talks with the men because men are the decision makers for everything. So we were really trying to make an effort of making sure that the men were educated amongst all the female kind of topics as well, so they could support the females in their life. This is another meeting with some more elders. So I was mentioning about the malnutrition rapid assessment that we had to do. So a lot of the time, before we did anything, we wanted to go to the community leaders to ask for permission and to get their acceptance first. And this is a huge part of the community engagement. We don't just go in there and just start doing something. We want to make sure that the leaders are on our side as well. So before we did this malnutrition assessment, we gathered all the elders together and explained about malnutrition, that we're concerned that there's concerns with food. We've seen some people with malnutrition in the clinic. We would really like to do a huge screening of the whole camp just to check what the malnutrition rates are like, and so we can refer you into nutrition services. So this is this is just a meeting just to ask for the permission, and they were very, very happy about that. But this was a huge part of our role, as we always had to go to the leaders first out of respect to say, this is what we're thinking about doing. How do you feel about it? Is this okay with you? So you can see at the back, this is the flip charts that I was talking about. So we have kind of like A3 size, usually images on there, and we kind of like show the group. And then it's usually like an interactive session. So we'll ask questions and we'll test them at the end. But yeah, this is just to explain about malnutrition. There's you can't really see it, but there's a boy and one child is malnourished and the other one is kind of not malnourished, to show the difference.
Are they always welcoming to these kind of interventions, or did it have to take some persuasion with certain topics and things like that? Like, how welcoming are they to you coming in and be like, you should do this?
Yeah. So I wasn't there from the very start. So I think it does take a bit of time to kind of gain trust and build that rapport first. So when I arrived there, that trust had already been gained. So I think they were very receptive to MSF. They really, really liked MSF, and they were saying, we don't want MSF to leave. Please don't pass us on to Afghan Red Crescent. We want you to stay. But yeah, it does take a little bit of time to kind of build the trust, and you have to just be culturally respectful as well, not push anything too much. And actually a lot of these kind of these topics and this information is usually being kind of co-designed with somebody that's local, and it's been pre-tested with like the local community just to check, is this acceptable for your culture or religion or language, or even kind of images? Can you understand this image? So yeah, there's a lot of work that goes on to kind of make sure that the information and the materials that we use is how do I say, acceptable. This was just a staff training session. So the malnutrition rapid assessment that we did, none of my team has had any experience in, do you know the MUAC measurement? It's like a little kind of tape measure you put around the arm, and that can tell you if someone's malnourished or not. So we had to kind of train all of our health promotion team from scratch. So this was just some of my team just practicing. I was pretending I was a pregnant woman, and yeah, they were doing the MUAC on me there. But yeah, so our tent was used for kind of training sessions, like on a weekly basis for various topics. I was mentioning before about the children's games. So a lot of the children in the camps are so bored. I mean, there's one school there, but you know the girls don't go to it. The kids are often just hanging around the camps with nothing to do. So actually, we decided on setting up some children's games, but incorporating education into that as well, because there was so many hygiene-related infections, especially in children with diarrhea, skin infections, that kind of thing. So every week we were kind of collecting like children of all the different ages, boys and girls, and like basically playing games. So we had kind of bubbles. So this is like you can't really see it very well, but my colleagues are kind of blowing bubbles, and they're trying to kind of depict that if you have got a cough or a cold and you don't cover your mouth, your germs might kind of go into the air. So it's really kind of just using kind of visual things like that to show like how diseases can spread, and trying to promote like healthy behaviors. So if you need to cough, make sure you cough into your arm, and make sure you wash your hands if you blow your nose, that kind of thing. We also had a game with glitter. So they pretended that if someone sneezed in their hands and they've got some glitter on their hands, and then they go and touch someone, you can see how the glitter is transferred to people as well, just to show the transmission of bacteria. But yeah, so I think this was really great because the kids were just, they were just excited to do something other than kind of sitting in the camps doing nothing. So yeah, there was a separate girls and boys session. So this is one of our teams for the malnutrition assessment. So because we had 6,000 people, 6,000 population, we had to cover all of the camp. We had to kind of borrow some staff from Afghan Red Crescent and also the MSF nurses and health promotion team. So we had to really kind of coordinate this thing together very, very quickly, train everybody. This is one of the teams, and it's just me there supporting like this team, really just kind of overseeing that. Are they doing the MUAC measurements correctly? Are they measuring the right people? Are they documenting the right information? But yeah, it was really, really good. And we actually collaborated quite well with Afghan Red Crescent as well. So it's quite nice to kind of see MSF and another NGO kind of working together for the same outcomes. So MSF were not providing a nutrition service for malnourished people. So it was actually benefiting the Afghan Red Crescent because they were providing nutrition services and malnutrition. So like the fortified food, like the plum peanut, which you've probably all heard about. So we were identifying referrals and then sending them to Afghan Red Crescent as well. So we found overall there was about 6% of children under 5 that were malnourished, which is kind of not a very, very high alert, but it's an alert that we need to do something about this. In the pregnant and lactating women, it was very high. It was around about 20%. So that was something that we kind of had to raise. When we left the camps, we handed everything over to Afghan Red Crescent, all the information that we had, and just to try and advocate, you need to kind of up your game a little bit with the food and the nutrition services.
About 15 minutes left.
So I've talked a little bit about the challenges faced, but yeah, just briefly, I would say kind of like the gender segregation was very difficult to get used to, and it just made you realize how much freedom we have as a woman here. We weren't able to go to the shop by ourselves without kind of asking one of the male guards, please, can you come to the shop with me because I can't go on my own. And even kind of practically when you're in a team meeting, I've got men and women there and I'm trying to explain the same thing to them, but they're separated. The women have their burqas on, the women are not kind of interacting very much. It was definitely very, very challenging. And I can just see how much kind of, how difficult it is for these women. to get by just in life. There was also the language barriers were a huge kind of barrier as well. As I was saying before, my team, only my health promotion supervisor spoke English. So it was very, very difficult for me to even observe or kind of supervise some of the information that my team were given. We did have some translators that were not always available, and they weren't very, very strong translators either. So this was definitely a difficult kind of challenge that I faced. Just before I arrived in the project, actually, there was a recognised need for a Pashai speaking translator. So luckily we managed to kind of recruit some Pashai speaking, which is a minority tribe and language, which did help a little bit. But yeah, just overall kind of the Pashto speaking, and it was very, very difficult to communicate with my team and really kind of know fully exactly what they're saying. So I was relying a lot on my health promotion supervisor, who was a male. I was relying on his judgment quite a lot. So as a female, him as a male was not able to go into the female sessions to observe their performance. So yeah, that was a real tricky one, and something that kind of has definitely been a learning point for me. And we usually, after these projects, we write a capitalization report to kind of talk about lessons learned, things like that. So that's something that I definitely raise, and kind of in the future projects, we need to make sure that we cover all the different languages that might be here, but also have male and female translators as well. I've mentioned a bit about the female staff restrictions. Also, another big challenge was, it was just very, very tiring, because we were traveling 2 to 4 hours in the morning, 2 to 4 hours back home every night to Jalalabad. So we were working 6 days a week. So in emergency projects, it's often very, very intense. It was my first emergency project, actually, but it's usually like that. It's quite full on. So I would say that was quite challenging. And also the travel into the epicenter of the earthquake in the smaller camp was very, very dangerous, actually. Yeah, very, very bumpy. I don't know if anyone's been in the MSF cars before, but oh yeah, we brought one to the festival, didn't we? The one that we worked at. Yeah. Yes. So yeah, that was kind of just a bit of a overall view of kind of the earthquake response. So does anyone have any questions about them before I move on to the new project? Yeah.
What female staff did you have? Like, how do they hire female staff, if any? Is it people that were skilled pre-2021 from the Taliban? What does that mean for women going forward? Yeah.
So yeah, the recruitment, I wasn't there during the recruitment, but there were the recruited people that did have an employment history. So for example, some of my HP team were midwives, dentists, social workers. So they had the skills and some of the education prior to that. But some of my team had just very basic education. So they were kind of learning a lot on the job. But for women, so the Taliban, they do relax the rules a little bit for NGO work. I don't fully understand them completely, but yeah, so women are able to work in NGOs, but it's still quite limited. Yeah, I'm not sure how to kind of answer that, but yeah.
And they'd have to be with just like that, moving between work and stuff. How does that work with a man? If they're in the female health, does that mean the men have to hang around, or can they leave?
Yeah, so actually, sorry, I didn't explain this before. So usually a man and a woman would be paired up together. And so if we recruited quite a lot of husband and wives as health promotion, or brother and sister. So they're able to, because they're a family member or a husband or wife, they're able to kind of travel around together. So that's acceptable. So a lot of the team kind of traveled around like that. Yeah, but going to and from work, yeah, there was also an issue. So we did have some detached like midwives or nurses from other Afghanistan projects from MSF, but they had to bring a male maharam with them, like such as their father or a brother, and they were just there with them in the project, just hanging around. So it's yeah, it's kind of a little bit crazy. Yeah.
I've got about 10 minutes left. I can do 2 questions. So
I'm interested in the female only space. So when you have those spaces, are you able to see a difference in kind of the communication that comes out and how people respond?
Yeah.
When they are just in a women only space?
Yeah, definitely. People, the women can remove their burqa and they feel more comfortable expressing themselves without any males present. Yes, I think culturally, yeah, they just feel more comfortable when there's not other men there. Yeah.
When it comes to like more soft skill behavior change things, so say with the sanitation stuff, with like the blowing bubbles with the kids, how do you measure success in practices like that? Like, how do you measure more soft skill stuff? I understand when it's more like, I don't know, patient, and then when you're like seeing patients, you can kind of have more metrics, but what would you do for more behavior change?
It's quite tricky actually because it's with a short space of time, it's really difficult to measure that change in behaviour. But my team, I know when they were going from 10 to 10, if there was any children there, they would often just do an ad hoc session, like, well, do you know how to wash your hands? Give me an explanation. Show me how you'd wash your hands. And so some of the team would actually remember some of the children from the children's sessions, and they would test them along the way. But yeah, I know what you mean. It's quite difficult to kind of measure that success and whether it has actually made a difference, especially in a short period of time.
Yeah, do you think on like a more ad hoc level there was a lot of buy-in by the children who were participating in it?
What as in?
Like, were they then washing their hands? Was sanitation practices improving?
I think so, yeah. I do think so, but I think because if you're just used to a certain behaviour for so long, that just becomes normal to you. So I don't know, actually. I think the team did say that they did see like a change in some of the behaviours, but I just don't think we were there long enough to really kind of analyse like how much of an impact it's really had. But yeah.
I've got a question from online. All challenges mentioned by you are super hard during operations. Also, you may face with psychological pressure. Did you have such pressure, and in what way did you handle it?
Mm-hmm. Yeah, it's yeah, I think when you're working these long hours and you're kind of seeing horrible things and hearing horrible things, like it's really difficult to take care of yourself. But we had a really supportive team. Actually, the international staff that we worked with were all very nice. We'd always check in with each other and say, how are we getting on? My project coordinator was saying, I think, Jules, I think you've been working too hard. I don't think you should go to the camp today. So, you know, that kind of thing. There was support there for us, and like we always know we can reach out to the staff health unit as well if we're kind of really not kind of feeling too great. But I think just having a really supportive team in general that can recognise if you're burning out or you're not feeling too good. Yeah, hope that's answered that. Okay. I'm aware that I've got a bit more to go through. So yeah, I just wanted to just briefly talk about the new projects assessment in East Afghanistan. So whilst MSF were there, we observed very high vulnerabilities whilst working in the Kunar province. And because the Taliban are not putting any money into the healthcare funding, there's a lot of gaps in healthcare, it's particularly medication supplies, staffing and facilities. So actually, Afghanistan in general does rely on NGOs to provide healthcare in general. There was a banning of one of the NGOs that was actually providing a lot of care called Jack. So I don't know if you've heard of Jack, but they left, and actually it's left a lot of the health centres in Afghanistan really, really low in supplies of medication. So we actually recognise that this is a huge issue. Also very high morbidity, mortality rates, really high poverty as well. So actually MSF OCB Brussels actually decided to put an assessment team together to try and scope out whether we could set up a new project in East Afghanistan. So this is actually what happened. Luckily, I was part of that team from the HP community engagement point of view. So I was very, very happy to do something I've not done before. But the team consisted of a deputy project coordinator, some support, PMR, which is the medical side, me as a health promotion manager, health promotion officer, water and sanitation manager, and then we had translators as well. So what we wanted to do is really, well, first of all, we did like a data review to really kind of like look at the areas of need. Is there any health centres or areas that don't have any NGO support, or maybe they're very hard to reach? Any kind of vulnerabilities, really. So there was a review done kind of to check reports. There was meetings as well with partners. And then that kind of informed a field assessment that we did with the team. So we kind of chose 9 districts. So there was 4 districts in Nangarhar and then 5 districts in Kunar province. So they were just next to each other. And these are the 2 districts that were most affected by the earthquake as well. And we visited 26 Ministry of Health facilities to try and interview the staff there, but also the communities, the women attending. We really wanted to kind of focus, like making sure the women had a voice, but also the leaders and the elders of the community as well. So a big part of my role as health promotion, I was in charge of really just trying to understand basically the community issues, priorities and needs, that just in general, but also after the earthquake. Has anything changed for you after the earthquake? Has things got worse for you? But also just to kind of see, what are the community reporting? Who's dying and why? And what's the main problems with health in your community? So it's really just to try and work out where is the most vulnerable need, where is the biggest needs. We're also trying to assess like health-seeking behaviour. So what do people do during sickness, during pregnancy or emergencies? Where do they go? Who do they see? Do they pay any money? How do they get there? Do they go to a traditional healer? Do they go to a Ministry of Health hospital? Or do they go to the elder that has some herbs or opium? Also, we're looking at what are the barriers for them accessing healthcare. And also we wanted to just collect community suggestions and solutions, like what is it that you really need for your community. So this was a really, really interesting piece of work. I was doing lots of focus groups and interviews with mainly females I was conducting them with. I had a female translator with me. And we had a male HP who was doing the male meetings as well. That's just a little photo of me. Actually, I was able to go in a male meeting. This is just in one of the health centres. This is my female translator here. Yeah, so we were just trying to really understand all these community needs. This one is a health centre with a male focus group happening. And this is another health centre which was really, really run down. You can see kind of it's just made from mud. And this is the waiting room here in this little kind of shack. So we actually found a lot of vulnerabilities actually, more in the Nangarhar province, which had kind of been a little bit neglected because most people had focused their efforts on Kunar province where the earthquake was the worst. But actually the other province, Nangarhar, also had a lot of vulnerabilities, but the NGOs weren't really supporting them as much as Kunar. I won't go through all these because we're running out of, we'll have a few minutes, okay. But yeah, just some of the things that kind of stand out for me is, I'll read some of the yellow ones. There were many deaths during the earthquake. People are frightened and anxious. We fear noises and small movements. So that was kind of highlighting there's a lot of mental health problems following the earthquake in general. People don't let their family members come to the clinic because they know the clinic doesn't have any drugs. So actually that was a barrier in itself, going to the clinic, because people knew that the clinics didn't have any medication, therefore they were just not doing anything about it. We have a lot of diarrhea here. The water's not clean. We have no water pump, only an uncovered bucket well. So actually there's a lot of like water and sanitation problems after the earthquake as well. It damaged a lot of the water wells. Also causing kind of extra kind of problems with diarrhea. Mother-in-laws don't allow the daughter to attend for family planning. They're illiterate, uneducated, and sometimes narrow-minded. That was a midwife that kind of expressed that. So yeah, there's kind of a lot of problems with barriers. But yeah, I'm sorry, I don't have time to kind of go through them all, but I'm sure we can share the presentation if you're interested. Yes, so I'll try and go really, really quick. So luckily, OCB Brussels, they did actually accept our proposal for a new project in East Afghanistan in the Nangarhar province. So we actually, we identified 3 health centres, these ones, to basically MSF will support those. So we'll either train new staff or recruit like the staff that are already there. Also, it would have a community outreach component as well. So it would be the kind of facility based, but also outreach in the hard to reach areas as well. So I'm sorry, I've got no time to kind of go through it too much, but this is the map actually. So Jalalabad is the office which we aim to kind of keep as the base. Kunar is up there. That's where the IDP camps were that we're working in for the earthquake response. But these 2 sections in red are the new areas that we've recognised as a big need. So for the first year, it will be focused on an area called Karma, and the second year it should be Darat Inor if nothing goes wrong. I mean, I know there's issues with Pakistan and Afghanistan now. Yes. Sorry, I've written that.
There's a comment that I want to read before she spoke up. She said it's been a privilege to hear you speak about your work, and I just wanted to agree. It's been great to hear from you, and I can't wait to hear more on Saturday when you're at the conference. But we have to go because
Okay, thank you. I'm happy to answer any questions. Thank you. I'm sorry if I've rambled a lot.